This program is brought to you by Emory University.
So welcome to our cardiology grand rounds this morning. It is a distinct honor to introduce our visiting speaker, Dr. Keith Churchwell, and wonderful to have Keith and his wife, Dr. Leslie Douglas Churchwell, back here at Emory. They have very important Emory roots, as you will hear, and I know many of you will be meeting with them today. So Keith was born and raised in Nashville, Tennessee. He did his undergraduate at Harvard, his medical degree at Washington University School of Medicine. If we look at his phenomenal CV, probably the most important part in his CV was his training at Emory. He was an Emory resident where he met his wonderful wife during their training. He was an Emory cardiology fellow and trained one of the first fellows training in cardiac imaging. Keith was my chief resident, and Keith had a really amazing impact on many young lives at that time, as he continues to have today. Even back then, it was clear Keith was a leader. He led by example, which he does today with grace and humility. And I was one of Keith's residents, and he set the bar high. He had expectations for all of us. Keith went on to many leadership positions, initially went back to Nashville, became a leader at Vanderbilt, where he was the director and chief medical officer of the Vanderbilt Heart and Vascular Institute. Most recently, he has had leadership positions at Yale, president of Yale New Haven Hospital, executive vice president and chief operating officer, executive director of Heart and Vascular Services there as well. What we learned last evening was Keith is still president of the New Haven Symphony Orchestra. Keith is now the president-elect of the American Heart Association. And we're just looking forward to his grand rounds today. He'll be talking about the journey to better, more equitable health, lessons learned from the pandemic. So I'm going to hand off to Dr. Churchwell. Again, it is such a great honor to have him here back at Emory.
Larry, thank you. Once an apology. Over time, as probably in my time in Atlanta, I developed allergies, which I never had when I was growing up. So I may cough a bit because your pollen is definitely out. As we landed, we figured that out. It's funny. The definite waves of nostalgia comes over you as you not only, for me, not only when we landed, but also when I actually came to the Emory campus, and hit me rather markedly as I came through the front door, because I've not come through that front door in over 30 years. And that has not changed, but everything else just changed rather dramatically. We were making the statement yesterday, when I left here, the CDC was a small red brick building, actually on Clifton Road. It's not that anymore as we go forward. So thank you again for the invitation and the opportunity to speak today. I thought I spent a little time talking about a subject that has become near and dear to my heart in my time, actually not only in New Haven, but also working with the American Heart Association over the past few years. And the responses that occurred actually in New Haven around the pandemic, those particular lessons, and the lessons I think it actually has taught all of us when we think about the delivery of care and the opportunity to improve the care for those that we have the honor to serve. I thought I would, there's a couple of nostalgic pictures here. So this is actually from this picture of Grady is from my first year as an intern. Google is a wonderful instrument at the end of the day, because you can find these things just sitting out on the web. So that's Grady Memorial Hospital in 1987. Grady was incorporated in 1890. Its first beds opened in 1892. The campus has had at least 4, if not 5 iterations at this particular point. What's interesting about the campus, of course, which was actually very consistent with many institutions across the country, it was a segregated campus for many years. There was the AB wing and there was the CD wing. By the time I was an intern in 1987, everything had come together, obviously. But when I was at Barnes Hospital, there was the private side and there was the public side, which actually was demarcated by the fact that the private side had carpet and you could order a dinner, and on the public side, you couldn't. And in Yale, New Haven, interestingly, it was to the point that there were literally two hospitals. There's the York Street campus, which was actually Grace New Haven, which became Yale New Haven Hospital, which whose clientele was the upper echelons and the white population, the white Catholic population and Protestant population of New Haven. And then there was St. Rafe's, which actually took care of everyone else. Of course, those campuses now, with St. Rafe's actually going bankrupt before I actually came to New Haven, are now two campuses of one hospital. And at this point, the St. Rafe's campus is actually undergoing $1 billion redevelopment. So it will be actually the newest hospital in the Northeast in actually 2 years. So things can change. And to the left, I say that because we all actually had our post office pictures done when we were postgrads, when we were first year interns as we go forward. Just a couple of other pictures. This is my chair of medicine was Dr. Yuha Koko, who to his wonderful credit actually reached out to me last week to congratulate me about my presidency with AHA and just to update me on how he was doing. And Henry Sadlow was our second year chief resident. And Henry has very close ties and firm ties with many of you, I think, in the audience, and has made an effort to really reach out and keep the extant Emory community together. And I appreciate Henry sending these pictures. To the left is actually my older brother, Andre, who many of you probably know, and Andre was on campus actually about a month ago or so, giving grand rounds. Also in this picture is my identical twin brother, Kevin Churchwell. Kevin is actually trained as a pediatrician, critical care pediatrician, and interestingly enough, has taken a very similar pathway, but one could define me as the runt of the family because he is president CEO of Boston Children's Hospitals these days as we go forward. At Yale New Haven, each and every day we have morning safety report, and a senior executive actually leads that report. And I had the opportunity for a number of years to come in and lead that report. And I started a tradition of actually having a quote for all those actually who are in the room and also on Zoom to sort of help them think through about what we were trying to accomplish and what our overall mission is. This is one of my favorite quotes. This comes from actually March of 1966, so almost 60 years ago. And it was at a Chicago press conference before a speech for the second convention of the Medical Community for Human Rights. The full quote is, "We are concerned about the constant use of federal funds to support the most notorious expression of segregation. Of all the forms of inequality, injustice in health is the most shocking, and it's the most inhumane because it often results in physical death. I see no alternative to direct action and creative nonviolence to raise the consciousness of the nation. So of all forms of inequality, injustice in health is the most shocking and inhumane." So MLK made this statement almost 60 years ago, and unfortunately for us, it is as prevalent and as new for us to actually conquer and move forward towards getting to a better place than it was 60 years ago, whether it be 60 years ago, 100 years ago, or 200 years ago from a country's perspective. So a couple of statistics, and this is pre-pandemic. So healthcare expenditures have been obviously significant and skyrocketing in this country and really across industrialized nations. This is actually data that was from a study from the Commonwealth Fund from a gentleman named Rob Snyder from a paper he wrote in 21, Mirror. And to me, it's remarkable data. So the red line, the top line is the United States. Their other lines are actually of the industrialized nations, mostly in Europe, in terms of the overall healthcare spending as a percentage of GDP. So the spending for GDP in the United States is actually 18% of the GDP is healthcare in this country. It's actually by far the largest amount that we spend. as a country in terms of for its day-to-day operations, more than defense, more than any other industry in this country. And you see that the gap is remarkably wide between the U.S. and the rest of the industrialized nations. So there's a money problem, but it's not that there's not plenty of money that we actually invest in and have for us to utilize to actually think about how do we take care of the population that we serve. But what you also find is that when we look at actually other important indices and thinking about the relationship in healthcare, how we fund it, what the outcomes are. When you look at actually healthcare system performance and defining equity, and equity is defined by this particular paper as our ability to measure access to care, care processes, and administrative efficiency. You can see that the United States is actually remarkably below the line in terms of performing in comparison to the rest of the industrialized nations. This is actually 2019. This is data before the pandemic. The supposition by the authors for reasons behind this, I think actually probably are pretty accurate. Number one, the other countries actually that were actually evaluated, they provide universal coverage and remove cost barriers for patients to be seen and evaluated. They also have very robust primary care systems to ensure that high value services are equitably available. And they also reduce the administrative burden that diverts time, energy, and opportunity for patients and for clinicians to take care of patients. And they also have invested in their social services, especially for children and for working ages adults, to achieve their overall goals. These are things that we debate as a country, debate every single day in terms of the overall importance, how to pay for it, who should actually be doing this work. But you can see the results of that in comparison to others who have actually engaged and have worked towards these particular goals and how we compare to them. So even before the pandemic, there was huge opportunity to think about the delivery of care in a more equitable fashion and in a way that actually has a larger impact on the patients that we serve. And then the pandemic occurs. So you're asking, what in the world is this slide? So, Epic is a wonderful tool. It could drive you crazy at 2 o'clock in the morning as you're trying to finish your charts. But it actually is a wonderful tool in the sense that it is all the data is databaseable. It's actually sitting in the background. And for Yale New Haven Health at the time, all the hospitals were connected, all the clinics are connected. So each and every data point in regards to the day-to-day operation, the day-to-day interactions with patients sits there. And you're able to extract the data. So this is data that we actually were able to extract from Epic every single day that helped us think about the pandemic and what was happening at Yale New Haven, and also across our health system, and also looking at the data longitudinally. So to the left-hand side, you see this graph, and this is a graph of actually the number of patients in Yale New Haven Hospital who were COVID positive, beginning in February of 2020, all the way through actually June of 2023. It turned out when we looked at the pandemic, you could literally see it marching up I-95. I-95 actually starts in Florida, goes all the way actually to Canada. And we live literally right now, just right off I-95. And all of our hospitals live off I-95. So we could see the pandemic coming from New York, actually marching through Greenwich, through Bridgeport, to New Haven, and to London. And by the middle of March, where we went from February, no patients in the hospital, we saw this huge increase. And this peak that you see is April of 2020. And at that time, we peaked at that point, 471 patients in our hospital who were COVID positive, whether in the ICU, step down, or in the ED every single day. And it turns out 471 patients, in comparison to the other hospitals in Connecticut, made just the COVID population the third largest hospital in Connecticut. So a response to that had to be rather dramatic. And you've read about the responses in New York. What we had to do, for example, is actually take our cancer hospital, Smilo Cancer Center, which had been built some 8 years prior, and we converted the whole hospital into a COVID hospital and moved all the cancer patients actually out of that particular area, which has led to a complete transformation about how we think about the delivery of cancer care for Yale New Haven. Because those beds were actually had the appropriate filtration and from an air system, and had ICUs. We were lucky in the sense of having that available. But it was actually not large enough. We actually had to use part of our campus, the St. Rig campus, to actually take care of this patient population. But we were able to catalog and follow patients in terms of their journey with COVID and non-COVID through this whole time period, and also see the statistics in terms of mortality, the morbidity for those particular patients, and how we approach them. Interestingly, talking about Yale New Haven a bit, when the pandemic started, we all had no idea how to take care of this patient population or what was the right pathway in terms of the overall therapeutic opportunity. So what we agreed upon was that we would let the data, let the science guide us, as opposed to being our personal opinion for each and every patient about how patients should be taken care of. So putting aside our own, at times, implicit biases of patients walking through the door and making assessment whether they would live or die, we looked at their clinical criteria regards to their oxygenation status, their blood count status, where they were in terms of their overall cardiovascular status, and then began forming plans and working towards how to take care of this patient population. And then being informed almost on a daily basis about what works and what doesn't work. And if you look at the Yale New Haven data and the Yale data regarding the pandemic, it's really interesting. And there we've actually formulated a paper that will hopefully come to JAMA sometime in the near future. If you look across the country, and we'll talk about this a bit, the standardized data for COVID showed that for African Americans, for American Indians and Native Alaskan Natives, for our Pacific Islanders, in comparison to the white population of the country, you had almost at times double the mortality and morbidity from COVID in terms of overall comparison. You look at the data actually from Yale New Haven and across our health system, African Americans and Hispanics actually did better in terms of their overall mortality. Had a larger number of patients who actually developed COVID, but actually less in terms of the overall percentage who died from COVID. So there's we think that there's an opportunity there in thinking about how the delivery of care, from the equitable delivery of care, and when we think about care in a very different way, is something that we want to talk about. And this slide also points to the fact that when you look at the age-adjusted mortality data, it is a significant difference between the two. So, you know, that particular canary in the coal mine was something that we probably already knew, became very stark in the overall reality of the fact that there is a different pathway and a differential of care between our urban and rural population, our urban and an economic impact, and also a racial impact when we think about care delivery that could have major consequences. So, and you know, so as you look, this is actually CDC data looking at the mortality numbers, and the mortality numbers from COVID are just remarkable. You're peaking at well over 1.5 million people dying who actually documented dying. The numbers are probably double when you look at the true numbers of people who died actually from COVID, because the autopsy data or the reason for death data could have been from diabetes or cardiovascular disease, but in actuality it was COVID. And then many people actually didn't die in the hospital; they've been dying at home. I would say that although we have said the pandemic has stopped, each and every month, when you look at just the Massachusetts data, there is actually at least over 100 people dying in the state of Massachusetts from COVID at this particular point. But there were a number of important events that I think brought to the forefront the issues of health equity and how we think about delivery of care in a way that got us around wanting to think about a different pathway, a different opportunity to actually address how we take care of every single patient who actually walks through our door. Two big incidences actually that were in the public domain. One is actually George Floyd from May of 2020. And what happened in Minnesota and Minneapolis, and the reaction in the Minneapolis community, but really nationwide, if actually international, to this unfortunate gentleman. And then what happened to Breonna Taylor, actually in Louisville, Kentucky. These were incidences that actually brought to the forefront a degree of disparity in terms of how we as a society have been approach individuals, especially in the African-American community, in terms of for the overall care and their interaction with police. But within that, how also we are thinking about their care within the health community. So a couple of, I think, points were actually made in terms of how we should start the process of approaching and addressing the issues of health equity within our medical community. Number one, we do need to work on recognizing the overall past. And what I mean by that is that what has occurred before us or previous to us has a huge impact on how we approach our day-to-day work. So there are a couple of, I think, just examples, but I think major inflection points that I wanted to make. Number one was the Flexner report. So Flexner's report had a huge impact. Actually brought forward the idea of the modern medical school and modern medical education to this country. Now, Flexner was not even not a physician, it turns out, right? He was a psychologist. His brother was a physician, but he was a psychologist. And he was asked to actually do an assessment of medical education in this country. And from the report, there was the development of the modern medical school. But it can't be overemphasized that the impact of the persistent lack of physicians of color throughout the workforce came from the recommendations of the Flexner report. At the time of the Flexner report, but it was actually at the turn of the century, there were hundreds of African-American medical schools in the country. I mean, some of varying quality, of course. There were hundreds of medical schools across the country because they were actually all apprenticeships. There was a willowing of the number of medical schools throughout the country, but specifically in terms of the Flexner recommendations, it was you need to get rid of all of them, but only keep 3. And the reason only to keep 3 was to ensure that there was an opportunity to take care of within certain communities, African Americans, and limitate their work to sanitation and taking care of the limited population. So those 3 were Meharry, were Howard, and Charles Drew, which was actually not Charles Drew at the time, on the West Coast. So hundreds of med school applicants, medical school residents who were actually within those schools wiped away at that particular point. And we're still feeling the effects of that over time in terms of thinking about the pathways of medical education for underrepresented minority communities across the country. The second example I always think about it was Henrietta Lack. Henrietta Lack was a patient at Johns Hopkins, diagnosed and treated for her cervical cancer. An ultimate death occurred there. Hopkins at the time, as were just about every institution in this country, was a segregated institution. Her cells were used for research and has truly led to a revolution in science in terms of therapy and the development of opportunities of pathways of care within not only cancer, but actually multiple modalities in terms of care. But for decades, that contribution, her contribution, was actually ignored, was swept away. And that the fact that she did not give consent, nor the family didn't give consent to her utilizing her cells, and an acknowledgement of their use was ignored. And that the policies that were widely held, actually within the Hopkins community and across the scientific community, were at the time very racist in terms of her treatment. With the publication of The Immortal Life of Henry Lack by Roberta Scoot in 2010, there has been a recognition by Hopkins and by many others in terms of her contribution to actually modern science. And they have worked very assiduously to actually recognize that contribution and move forward actually within the Hopkins community in a much better way of thinking about the relationship between science, medicine, the community that they serve, and developing partnerships and thinking about in terms of those next steps. And third, I wanted to talk about Georgetown. So Georgetown actually in this particular time has done a recognition, as has many institutions across the country. Harvard's actually has now published online in terms of understanding and acknowledging the fact that many of the buildings on the Harvard campus, undergraduate campus, were built by slaves. Many of the senior leaders on the Harvard campus actually had slaves in their households. The contribution actually on the Harvard campus was quite unique. Harvard would not be Harvard without slaves. Yale would not be Yale without slaves. Georgetown recognized that. There was actually a distinct decision made by the Jesuits, who actually started Georgetown, to sell their slaves to communities in the South to pay for the development of the university campus. And they've gone so far actually to detail and acknowledge every single one of those individuals that they could find their families at this point, and most recently has set up a scholarship program to say if you are a descendant of those families, that you will get free tuition to actually come to Georgetown. So recognizing the past and thinking through how we should think about the future, I think is very important, is a real common theme. I've been a volunteer for the American Heart Association for well over 20 years. Many of you probably started the same way. I started at the local board and thought I was going to make a difference. And next thing you know, you're actually being asked to do this and do that. And the next thing you're asked to actually be the chair of the advocacy committee for 4 years. And you find yourself deep within the overall mission and the intent of what I think is a great organization. I was asked in the midst of all this to bring forward a presidential advisory that had been brewing for AHA for a number of years. And this was the time that the organization thought it was appropriate to actually move forward with this, to think about a call to action to define the relationship between structural racism and as being a fundamental driver of disparities. And I think importantly in this conversation, it is not working towards saying each and every decision that we make from a medical standpoint is racist in its overall intent. It's understanding the framework of how we, from a medical education standpoint, in terms of our day-to-day operations, in terms of how our buildings were built, in terms of our relationship between our campuses, of the impact of the decisions that have been made for this country over the past 400 years, continues to have an impact in terms of our ability to deliver care. So with a great group of folks, we actually went through, with remarkable expertise, went through an exercise of thinking about these issues across a rather broad framework, and then relating them to their impact in terms of our care delivery. This is a slide from the paper. It's one of my favorite slides. Dr. Elijah Williams, put this slide together, thinking about the timeline of decisions made at the federal and actually at the state level regarding the relationship between African Americans coming to this country, and then ultimately the impact it has had in terms of our delivery and our ability to deliver care. And I think one of the things that strikes me about this slide is the fact that each and every time over the past 400 years, and specifically over the past 200 years, that we have actually moved forward in addressing the issues of a population that was actually brought here against their will. My family, my ancestors, Leslie's ancestors, many of the ancestors in this audience, and working towards the next stage in terms of making a more equitable society. There has been a pushback, a significant pushback that has led to ultimately a decrease in our ability to have an impact in changing the way that we actually approach our day-to-day lives. Great example is actually with the ending of the Civil War and the Emancipation Proclamation, the 14th, 15th Amendment. Ultimately, what happened was that Jim Crow came into the South. With the development actually of an opportunity for African Americans to actually join the federal service, there was, at the beginning of the 20th century, a huge impact in terms of migration north, and actually multiple individuals, multiple families becoming members of the federal workforce, which allowed them to have a pathway for monetary advancement and ultimately educational advancement for families. Woodrow Wilson came in and actually put a law in place that banned African Americans from working in the federal government. And doubled down by then putting in redlining as actually part of the opportunity in terms of neighborhoods across the country, unfortunately. And with the GI Bill initially would not allow African Americans to use those particular funds or have access to the funds for their education post-war. So this, you could see that there's this back and forth and to and fro that we have to understand, realize, and then think through what are really the processes that we need to put in place as we go forward to address the issues in the past that actually still are within the framework, many times, of the day-to-day work operations of not only medical institutions, but institutions across the country, and working towards how do we actually move forward to bring a much more equitable way to approach these particular issues. I really like this slide. This actually was from a paper that was actually in the Harvard Journal from a gentleman, Jay Shaw. The Harvard Journal actually, throughout the whole pandemic, actually did a sort of almost a quarterly assessment of how things were actually progressing within the country, and trying to do not only an assessment, but also thinking through what should be the next steps. What is our opportunity for learning? How is our opportunity to address these issues? And what became very evident actually in the pandemic, that there was a huge impact in terms of our ability to deliver care in the most effective way based upon the social determinants. I'm thinking about the fact that we have significant degrees of economic instability, the social and community context of actually how we deliver care, the neighborhoods in terms of how we live in, both from an environmental standpoint, from an educational standpoint, and from a social standpoint, and how that has a huge impact in terms of care delivery, and educational access and the overall quality of education. And within the country, within our public school system, private school system, how that has evolved in each and every hamlet, and its great impact on our ability to actually, for people to move forward on their chain for their overall growth and development, and to achieve their overall opportunity, their greatest opportunity, but also its great impact in terms of the overall health of the community. I spent the last, I left here and I was a clinical cardiologist and saw patients, thousands of patients in multiple hamlets throughout the state of Tennessee. But somewhere along the way, I raised my hand and said that there was a number of issues that needed to be addressed in the development of the Heart and Vascular Institute at Vanderbilt. And I got touched on the shoulder, said, it's your turn to think about becoming an administrator. So I have the opportunity to have the unique lens of a clinician at the bedside, which I think is incredibly important in thinking about the delivery of care, but also the issues that each and every day that from a C-suite executive of working towards how do we pay for this and also expand our opportunity and work towards the development to ensure that the lights stay on, as I always say, and the doors don't stay locked when we actually try to get into a building. And there is actually a robust business case to think about how do we work towards a greater stage, a greater opportunity in terms of health equity. The total cost of racial and ethnic disparities in 2009, again, before the pandemic, was actually $82 billion was calculated, with $60 billion in excess healthcare costs and over $22 billion in lost productivity. The economic burden of disparities was projected to be over $353 billion by 2050 if no real change occurred. And if we look at the projection, if death rates and health outcomes were equivalent between high school and college graduates, That would translate to over $1 trillion in savings in the United States. $1 trillion that we would save actually within the healthcare, by healthcare. We're looking actually in terms of expenditures and our appropriate use in terms of revenue. If we were to tackle these issues in a way that lifted our communities in the ways that we actually all want to. So healthcare organizations are, with this, can likely and we should see the return on investment from addressing these particular needs. Now, each and every nonprofit organization, healthcare institution, hospitals, actually have to, at the end of each and every year, give a report to the government, because we're not taxed, of course. But in a great sense, the tax that we pay is actually our investment in the communities that we serve. So we do a detailed monogram of that investment. You know, the greatest majority of that investment that most organizations detail, it's actually the resident and fellowship programs. That's the greatest amount of money that they put on that particular paper in terms of investment. It's very appropriate, very important, because we continue to actually, we are the vehicle of graduating the next generation of physician scientists, of clinicians, of medical practitioners that will take care of all of us as we grow older, or find the new advancements and find the new therapies that actually will enhance our lives. But the fact is that that can't be the only investment that we as organizations need to make. We have to invest in our communities. I came to believe, as I worked within this environment, that we do a fantastic job, especially over the last generation, since I was an intern to this point in life, of delivering acute care. The advances are just, were unimaginable when I was an intern. But I made this statement last night but the frustration is for many of our patients, we do these great things, but then 2 weeks later, they're back in the ED. Or a month and a half later, they're on dialysis. Or they come in to see Dr. Clemens in the clinic and their blood pressure is still not controlled. How do we actually think about joining patients with the opportunities that we have along their journey for care, all of our patients within every community that we serve, to optimize and enhance care so they can actually live the fullest life that they can? I think there is a financial opportunity to address this in a way that allows organizations to pay for this by the restructuring of how they think about the delivery of care, their overall investments across the continuum to achieve these overall goals. There are a number of institutions that actually have gone forward and actually thought through this and are starting to make these investments. To the right, you see Montefiore actually gave $200 million to pay for housing in their community. Housing was a huge issue. Homeless, not only homeless, but also people who actually had significant decreases in their ability to live within an environment that was productive, not only economically, but socially, but also from a health perspective. So $200 million just to pay for housing. And Kaiser Permanente in Oakland, Bernard Tyson, who was a remarkable gentleman, who unfortunately died of sudden death and had actually known coronary disease. That's sort of a terrible story. Who started actually as a physical therapist in Kaiser and became the CEO of Kaiser Permanente, made a huge commitment before his death to actually pay for housing in Oakland, over $250 million. Told his board actually had significant issues with it. And he turned to his board and told his board, I'm just going to do it. And if you don't like it, you can fire me. And nobody wanted to fire Bernard at that particular point. So the impact has actually been profound. And the left-hand side, there are a number of institutions, many of them children's hospitals, that have gone forward and thought about their communities in terms of their overall investments in different ways, in terms of the social context, not only in terms of housing, but also from an educational standpoint, and also thinking about the employment opportunity that they can make within the communities that they serve, that allows people to have the right pathway and families to have a pathway, a different pathway, and developing their relationships with the community and enhancing their overall opportunity, but also having the funds available to ensure that they actually have proper health, pay for their blood pressure medications, go to see their doctor. not go into significant debt when actually they have a medical issue, or not avoiding coming to see their physician because they can't pay for it. So I actually have been on the executive board of the AHA for the past 5 years. And Heart Association, back in the early part of this particular millennia, came to a difficult conclusion. Each and every 10 years since the middle of the 20th century, the Heart Association has made 10-year goals and thinking about the reduction and the elimination of cardiovascular disease and cerebrovascular disease in this country. And then outline those goals and then work towards how to make those goals possible. So the 2020 goal for AHA was a 20% reduction in cardiovascular death and mortality and cerebrovascular death and mortality for the AHA. A lot of great work done actually in multiple communities, multiple academic institutions actually involved to think about the research needed, the scientific breakthrough advancements, the advocacy actually at the local community and federal level to think about legislation that actually has an impact, and also the tools needed for the local clinician and provider to actually help to make the impact. Rosemarie Robertson, who you may not know, Rose was actually a cardiologist at Vanderbilt, a remarkable woman who was a science officer for AHA in the middle part of the last decade. Came to actually the board meeting with the announcement that we will not reach that goal. This was actually 2015. We're not going to reach the goal. Looking at the data, there's just no way. All the hard work that we've been doing, we won't come close to reaching the goal. What was the reason behind that? Well, the reason behind that was that the communities that the AHA had decided to have an impact on were not the right communities to actually help reach the goal. So underrepresented minorities, Hispanic community, African American communities, American Indian, Alaskan Native communities were not actually, had been thought to be part of the overall goals in terms of the work that was being done to address the overall needs. But in actuality, were actually not being impacted in a way that would lead to a significant decrease in blood pressure, reaching the overall hypertension goal, a significant decrease in actually the MI rate. You know, each and every year, unfortunately for us, we will have business until you retire, right? So each and every year, over 600,000 people in this country die from cardiovascular disease, sudden death, acute MI from heart failure. We still are number one on that list. Cancer has not caught us. They thought they would catch us. They were not going to catch us, unfortunately. In actuality, during the pandemic, it became worse, not better, as we go forward, despite great work over the past generation to actually decrease the overall rate. So that was an enlightening and a wake-up call for AHA to think about how they, the work that was being done across the spectrum, the investment in science, the investment actually in the guidelines, investment in advocacy, and how it actually pertained to the mission of wanting to reach actually robust and appropriate goals in terms of reduction of cardiovascular disease. So from that has come a statement of Heart Association on Health Equity and Structural Racism commitments that actually was a companion to our paper. And it became to define how the AHA wanted to think about as an institution to address these particular issues. The investment, true investment, financial investment of thinking about solutions, addressing the problem and thinking about solutions. So over $100 million was actually put on the table. Thinking about and working on developing partnerships with communities, with organizations within communities and individuals to think about and hear their ideas about how we can approach and address these health issues in more unique ways and more directed ways that actually would be more responsive in the communities that we serve. How do we work on with our partners to improve access? Leveraging our ability to advocate not only at the local level, at the federal level for legislation that would have a real impact on the decreasing the overall and reduce the rate of cardiovascular and cerebrovascular disease and where we live. And how do we collaborate to a greater degree with C-suites across the country to have them understand what the burning platform, the burning issues are, how it's actually having a huge impact on their employee workforce every single day, and work towards solutions to actually improve the overall health of those workforces. And with that, our board signed off on a strategic framework in terms of the overall guiding values, how it should relate to the vision for AHA over the next 100 years. AHA is 100 years old this June. We'll have the big to-do because the signing of that particular document actually happened in June of 2023 at the Drake Hotel in Chicago, Illinois. But this will be the 100th year, so it's a unique opportunity to be a president of AHA at that particular point. And working towards understanding for everyone who are part of this, what is the strategic value proposition to say that this work is going to have an impact, that has an impact that's going to have from a social standpoint, a health standpoint, and a financial standpoint that's going to make sense for everyone. And AHA also did something I think many institutions can look towards as a template of thinking about from an internal standpoint, what are we doing? What are they doing that's actually addressing this issue and moving AHA forward in a way that makes the whole institution a more equitable institution, an institution that actually thinks about equity not as a kludge or we're bringing it onto the overall mission, but actually is intercalated throughout the whole mission of the organization. And it has a unique opportunity because it actually has a strong advocacy arm. Then the quality improvement programs actually are evolving to the fact that having equity and health equity as part of the not only recommendations, but actually the criteria for Get With The Guidelines is actually working for it. That we can lead in this particular space, not only within the AHA perspective, but also across the country. How internally and addressing and assessing from an HR perspective in AHA, how that particular organization, how this organization is actually living what they are actually saying to the public domain, and also addressing what is the science behind addressing these issues, improving these issues, and how does it truly relate ultimately to the improvement of the overall health of the community. So the next step that we've gone through it is that we recently had a policy statement that we came out with that looked at actually what can we do very concretely from a public policy standpoint of addressing the issues of structural racism at the local, at the national, at the regional and the national community perspective. And I had an opportunity to work with Michelle Albert, who is past president of AHA, wonderful individual, to bring a group together to think through and put a policy statement together that looks at these recommendations. And the principles that we used, I think this is a wonderful slide in terms of a figure to help institutions think about how they can actually start approaching these issues within their own organizations. Number one, thinking about this within an equity first lens. We many times finish a project and then we actually think about the equity part of it at the end, as opposed to starting with actually understanding that part of the goals is actually making sure that we have the hugest impact across the whole community that we serve. There's an opportunity for great partnerships, not only with other healthcare organizations, other academic institutions, but with partnerships and those who are actually already invested in the community in terms of improving overall care. And how do we work with them, help enhance the work that they're doing, understand how they have been successful or where they've not been successful, how we can help them have a greater degree of successful with these partnerships. Work towards adapting sustainable and scalable frameworks in terms of this overall work. Think about the lived experiences of those that we are actually serving and how it should relate to putting together plans and operations that ultimately can hopefully lead to success. And work towards having true mechanisms to measure what success really looks like. Sometimes that could be quite ephemeral, right? How to measure what you're trying to do. especially in this particular domain. But working towards really defining those particular details that we could actually put on a piece of paper, have the database in the background, and actually address whether it's working or not working, and understand the reasons why in both situations, what we can do. From a policy issue standpoint, we decided that there were a number of actually high points we actually would want institutions to address: access to education, environmental health, public health and data infrastructure, which is, I think, the pandemic, again, opened up a Pandora's box to have us as a country to understand we don't have a public health infrastructure. We don't have although we talk about data, we talk about technology, we're all excited about artificial intelligence, et cetera, but the fact is, underneath, in many cases, it's just still on paper, or it's still in actually someone's head. It's really not actually identifiable for us to go and actually say, we can actually, from a tactile standpoint, say that this occurred because this is the reason why, because we have the data to support it. And how do we actually start the process of putting a true infrastructure across the country for you to be able to access that data and actually make decisions? And then true civic engagement across the spectrum, not only within the healthcare continuum, but also at the level of the local legislatures and also community leaders and those that actually work with community leaders to be engaged in this particular work. So when we think about from an organizational standpoint, how to achieve health equity and for hospitals and for health systems and for overall institutions, there's a great framework that was actually put together by IHI a number of years ago to actually have as the template for, I think, for us to work towards becoming better at this, to really engaging the fact that it becomes really part of each and every decision that we make so that we can move this particular needle forward in the right direction. Number one, making health equity a priority. Demonstrating true leadership to improve health equity, and secure sustainable funding to invest in these new models and the models that work. This is always a big of the bugaboo, trying to find the funding to do this. I would make the argument that there's plenty of funding. How do we work towards making sure that funding is used effectively is going to be key. We need to develop structure and processes to support health equity work. Establishing the right governance committee within our institutions to oversee and manage health equity work, and have dedicated resources across organizations. One of the lessons learned in the pandemic is that there was just a mushrooming across many organizations, whether they be health, non-health, within multiple communities, of defining the health equity officer or the office of health equity. And what you found about 6 months ago, 8 months ago, people were resigning from those particular positions, or they were closing the offices because, number one, they didn't work or they weren't effective. The fact is that we just didn't make the right investment, and understand that this is long ball, this isn't short ball. When it's taken 400 years to get to where we are, it can't take 6 months to actually fix it as we go forward. So really having sustaining in terms of the overall economic funding and really the overall investment is going to be incredibly key. Develop specific strategies to address the multiple determinants of health in the communities that we serve, that we can have a direct impact on, I think is going to be incredibly appropriate. We talked last night about healthcare services and the fact that healthcare is evolving to the real team approach to actually optimize care. And the fact is that from a patient's perspective, having an advocate actually within the clinic standpoint or the hospital standpoint, and also at their home to help them understand the care that's being delivered, the reasons behind it, why it's important to actually for these steps that their clinician has actually detailed, and to ensure that they not only understand it, but they're actually having the appropriate response. And if they're having adverse events, that they get communicated actually appropriately. Really improving the overall socioeconomic status of the patients that we serve. Having a greater understanding of the overall physical environment the patients live in, which is, and many times, remarkably toxic at this particular point. We have multiple examples, whether it be Flint, Michigan, as a great example of an environment that actually will lead to actually an inhibition for an improvement of the health community, of the healthcare of a whole community, based upon decisions made at the local and federal level that we need to address and actually be able to move forward. And help define and actually have the individual and the community understand what are healthy behaviors and how they can actually change the way they actually approach their day-to-day life to improve their overall health and improve their overall, enhance their overall lives. We need to work on how do we decrease institutional racism across organizations. You know, it's in the, we talked about the A and B side and CD side of Grady. We talked about Hopkins. We've talked about multiple organizations that actually have needed to evolve. And when we make new spaces, how do we actually ensure that those spaces actually don't come back and do the same over and over again, the same problems that we actually had previously? Ensure that health insurance plans are accepted by us so that actually they can pay for the overall mission. They have the right investment in terms of what is needed for the patients that we actually serve so that we can provide the care that is needed. And work on ourselves in terms of thinking about as we walk into a patient's room, walk into and talking with the family, how do we understand what our own implicit biases are locally within the organization to overcome those and think about our patients actually in many cases, many ways, in a different light in terms of what their lived experiences are, how we can relate directly, more directly to them because of those, and how we can work with them along, join them along their particular journey to actually optimize health. And to work on greater degree of partnerships in the communities that we're involved with, because there are many organizations in those communities that are actually doing active work, who understand that these are issues that are very prominent for them, that actually they have decided to infuse time, effort, and money to try to work towards, and that we don't have to reinvent that wheel. We don't have to actually bring other investments within our own institutions to fix those problems. We can join with them and align with them to have them help us in terms of fixing these particular issues. I had a picture here at the end. You know, at my time in New Haven, we developed a community of administrators and clinicians who actually, I thought, worked very effectively together. That was, if you look across that particular picture, they span the spectrum in terms of color, race, and gender, but all invested in the work to keep the lights on, and the work to ensure that we had the resources available to buy the next 7 Tesla magnet, to build the newest, brightest cath lab that we actually can put together, to ensure that the patients' rooms are actually 21st century, not 19th century in terms of how we, in terms of what the patient actually and the families and our nursing staff and our clinicians have to deal with on a daily basis. But also invested in the fact that we knew that that we were continuing to fail, and our opportunity to have a greater degree of not only investment, but a greater degree of impact on each and every lives that walk through our door, and how we can work every single day to think about enhancing our roles in making us a more equitable, not only society, but more equitable in terms of how we deliver care that we have the honor to do. So thank you, everybody. And I guess I'll take questions. Yes.
Hi, good morning. Cheryl Heron. I serve as the Chief Diversity. Oh, thank you. Good morning, everyone. Cheryl Heron. I serve as the Chief Diversity and Inclusion Officer for the School of Medicine, also an emergency physician, so resonant with what you're saying about recidivism to the ED. But one thing that is clear, knowing the historical tenor of what you speak about, is we're here now with the anti-DEI legislation assault. We went from 71 legislations to 81 in the space of a month. How would you posit in an election year that we think about these constructs to move towards health equity, where there is so much resistance, as you have demonstrated over time, to take us where we're trying to get to.
So
Thanks.
yeah, it's thank you for the easy question right at the beginning. I really appreciate that. So, it's a great question. And number one, for my thoughts about it, actually, I look at the historical narrative, because if we didn't know this was going to happen, shame on us, because it is an easy prediction, because it has happened every single time. But we do have a greater opportunity, a unique opportunity, because the bully pulpit, the public opportunity to actually address this issue in a much more comprehensive way, whether it be TV, through the internet, through whatever mode that your people are comfortable with, to actually call this out and have people understand that the fact is, we don't address it now, our children will have to. Their grandchildren will have to address this, because that's actually what happened, and it'll be worse, not better. Especially with the next pandemic, when we get the perfect virus like COVID comes into our community, we will again see this, unless we have actually worked towards putting plans and processes in place that addresses these issues. So we have to be very public, push back in all this. I mean, what in Montana, the governor said DEI is actually evil. Evil. Okay. All right. Great opportunity to push back on that.
Keith, it's with you 30 years
Michael,
ago.
hey, man.
Good to see you. How has Yale New Haven used the social determinants of health to further health equity? And what recommendations can you give us? We started EPIC 18 months ago and we're in its infancy. So we're wondering how you're using this to help further health equity.
So I can only say, here's my perspective. It became very evident that if we were going to depend upon our physicians and our nursing staff to actually address these issues and the 15-minute visit in the office, we were going to fail and fail miserably. So having a greater degree of investment for those with a team, whether it be the APRN or a community individual who actually is invested in that particular individual and family, who advocates for that particular person, who also helps to actually ensure that the information that is within the system gets back to, and that we actually are thinking about these particular issues to a greater degree. And also has an opportunity to understand what are the resources that are out there available to address these issues that are outside of the domain and the capability of the organization to bring forward. I think has been important. And New Haven's on
to go back to the mic just.
Oh, I'm sorry.
Because you're connecting.
I'm connecting across, and
Virtual world out
I'm
there.
starting
Yeah.
to get too active here. So I think that's important. It is not something that we can do. That EPIC, with all of its faults, which are multiple, but the fact is the data is there, and how we can actually have insight into the data and then utilize resources that are outside of our usual domain, right? Of your 20-minute visit actually in the clinic, but having some degree of opportunity for those to actually have true follow-up, advocate for the patient, and also part of that team to actually understand what is the journey this patient is truly on that's going to help us achieve and enhance the overall care for that patient. Yes, Larry.
So Keith, great presentation. I guess thinking about all the worlds that you're in right now, healthcare systems, certainly the American Heart Association, and as we think about public health and population health, related to not only cardiovascular disease prevention, but health inequities. We know the greatest drivers of these health inequities are cardiovascular in nature. In fact, hypertension control. There are three things that we know can close these gaps more than anything. Improving hypertension control for all. In our country, 25% of those living with hypertension have their blood pressure under control. Cholesterol management, 50% of those with known heart disease, hypercholesterolemia greater than 190 LDL diabetes, 50% or less are on even a statin, let alone PCSK9 inhibitors, and then mentholated tobacco use. If we tackle those three things at the level of health systems, community, we will begin to close those gaps. But then you said, you know, in the C-suite, you're thinking about keeping the lights on, the doors open. Why are hospitals and health systems not investing in these simple approaches to care that we know the answers, but yet,
Yeah.
you know, we're driving
Yeah.
lots of
Yeah,
high ticket items.
Yeah, Larry's great. Keep it simple, stupid, at the end of the day, right? Now, you're incredibly important points. I've been part of the menthol cigarette debate here for the last few years. I got sucked into that in terms of trying to move that in the right direction. Larry, I think part of the issue that we're going to have to continue to work on and drive home is to ensure that those who are at the level of making decisions from a monetary standpoint truly understand the consequences of our actions. That we need to continue to drive home and give not only palpable examples, but actually have them truly understand that actually doing this work will lead to a greater efficiency in terms of our day-to-day work within the healthcare environment, will actually not only enhance revenue, but will lead to a greater opportunity to actually use funds in a very different and unique way to ensure that the mission for each organization is actually achieved. I reflect back that when I was an intern at the Grady Clinic on Friday morning, and I had a patient with wicked hypertension. Wicked is the Northeast term. I learned what I was going for. That I had at my disposal Aldamet, Reserpine, and short-acting Procardia, which Dally Hall told me never use at the end of the day, right? These days, the armamentarium is broad and expansive and can be minimal in terms of the overall costs to the individual, to the organization. How do we continue to hammer this home, to put plans of action in terms of development is going to be key. So we've got to continue to be on the bully pulpit to have everyone understand this, but also understand the language that people will respond to and will resonate them actually at the particular hamlets that we're actually bringing the message to.
Keith, that was fabulous. Last week, I was at a meeting with Tony Fauci, and so a question came up. Why did America have the highest mortality from COVID of any country in the world except one small country in South America? And he mentioned all kinds of things like we have a lot of obesity and we have a lot of diabetes, and we have, but health inequity was his main point. And you pointed out that we don't really have a public health system in this country. So my question is, the Heart Association has been so effective in local communities. I went to the Heart Ball. They raised tons of money. They raised it from people who had a lot of money. My question is the Heart Association in the business of lobbying for public health?
Yes.
On the governmental level?
Aggressively at this particular point.
Because we're in a war, as you see,
yes,
between DEI is evil, anything that smacks of social is evil, and how do we combat that? And how does the Heart Association show its weight behind?
It's a great question,
public health?
Spencer. The Heart Association actually is in a unique space to do that lobbying, because it is always thought to be an independent arbiter, one that actually is not on one side of a political issue or the other side. It's on the side of actually improving the health of the community. So those particular points that we advocate for and should advocate for, both at the, and it's interesting, you can make actually a greater impact at the local and regional level than you can at the federal level in terms of changing hearts and minds that actually will lead to improvement. Just very recently, with aggressive efforts from AHA and from other organizations, Missouri became part of the ACA, which they said they would never become. South Dakota actually passed the ACA. North Carolina, who said never, it was evil
It was actually, the devil was actually a part of the workings of affordable care, past the ACA.
Can you help us in Georgia?
George is on the list at the end of the day. So an opportunity to understand exactly how this was accomplished, that again, it's long ball, not short ball, actually getting this work done. And that we have to keep pressing the point is going to be key. Yes.
Keith and Andy Smith.
Oh,
As you know, hospital administrators are very interested in Medicare reimbursement and the tie to metrics. And one of those metrics has to do with heart failure. And I was surprised as I'm getting more involved at Grady now to find out that social determinants of health do not actually play into those metrics.
Yes.
And as I see patients readmitted multiple times who have housing challenges,
Yes.
and to then see that the hospitals taking care of those patients are going to be penalized
Yes.
because of that. And I think that needs to be a key thing on the AHA radar.
Yes, yes, yes. You know, there are actually a number of projects across the country that are, people have some degree of malleability with, of using some of those Medicare and Medicaid dollars to actually support food and to support housing, to help address these particular issues. And I think from some of those particular projects, there's going to be important data that will come out that's saying that from a local standpoint, this is great, but we should actually think of this from a national perspective. And that we need to change the metric. We need to really understand, you know, I hope that we understand that this is an iteration. There's nothing really set in stone at this particular point, that we're actually part of a learning organization, both locally and broadly, and that we don't know what the real answer is, but we're actually trying to achieve and work towards what the real answer is, and should be open to new ideas and opportunities as the data starts to accumulate and address the issues.
Thank you so much for your great presentation. We welcome you with open arms back to Emory, you and Leslie, and have a great rest of your day.
The preceding program is copyrighted by Emory University.